usually if you leave it there, then over 50% of patients will have residual obstruction. And a patient that has obstruction, they have a lower quality of life. They have worse PTS symptoms. So those patients need to adapt to this situation. So they sometimes change their jobs. Or when they have a job, they need to adapt and they have to be able to walk several times every hour because they can't sit still. They can't play sports anymore sometimes. They can't go with their friends or family if they take a long trip and they need to walk, so they cannot keep up. And they have also problems of having these visible collaterals, which they find disturbing, but also they can be very painful. So you have a patient that just has a lower quality of life in the end. So in the Erasmus Medical Center, when we have a patient with an iliofemoral DVT, then they are admitted through the ER usually, but sometimes another hospital calls and says, okay, we have such a patient, can we transfer them to you? Then we also always have a multidisciplinary meeting, so we discuss together with vascular surgeon, interventional radiologist and hematologist, is this a suitable candidate? And then we discuss, of course, with the patient too, so we give the patient the options too. For us, it's important that at least the iliofemoral tract is obstructed. So if it's only a popliteal vein thrombosis or femoral vein thrombosis, we will not treat interventionally. But if the clot is higher up, so also common femoral vein, iliac vein, then we are considering them for treatment. What we always do is to do a CT scan as well. So usually start with a duplex ultrasound, so then the thrombus is diagnosed. We do a CT scan of the abdomen to see if there is any reason why this patient had such an extensive DVT. Sometimes you find a malignancy, sometimes you find a chronically occluded inferior vena cava, so I think it's important to know upfront what you're dealing with. And of course you have to have a patient with symptoms. Although, in my opinion, an iliofemoral DVT patient usually has quite severe symptoms. I mean, they must have swelling of the leg, they must have pain. Last, we find it important that this is a patient that has a good life expectancy. Although we use it sometimes in a palliative setting when patients have cancer and we want to give them comfort in the last part of their life, so that can be a reason to take clot out, but usually we do it to prevent problems in the long run, so you want the patients to have like a couple of years ahead of them, of course. The clot retriever gives the advantage that it doesn't need to be a clot that is like 2 or 3 weeks old. And we often don't know. So patients come to you and they say they have symptoms for like a week. We recently had such a patient, symptoms were like 1 or 2 weeks, but then we found also that she had an obstructed inferior vena cava, which she didn't feel apparently for all those years. Now the new clot she felt. So it's very difficult to define how old a clot is. So for clot retriever, that's a major advantage because it doesn't really matter if the clot is 2 weeks or 6 weeks or 8 weeks old. While when you would only have thrombolysis, then that matters a lot and your therapy will fail. And you don't get the patients always immediately because they're not referred, because they didn't know they had a DVT, because maybe you didn't have the time frame at that moment to treat the patient. So it's an advantage that you have sort of a bigger window for treatment. And the other major advantage is, in my opinion, and that's what we have to aim for, is to try to get clot out without using thrombolysis. For one, it's riskful, so you get more bleedings if you would use thrombolysis. And two, very important in my opinion, the internal medicine doctors that are referring these patients to us, they are very, very afraid of the thrombolysis and the risk. They don't usually even believe that it's an advantage to take it out, especially when you then have a treatment option that increases risk of bleeding. They will soon say, I'm not going to even refer the patient because I don't really believe it helps, and everyone gets bleeding, so and they don't even call you, so you will never know about these patients. So if we want to try to convince them, we need to have a method to get clot out without increasing risk of things like bleeding. But of course, mostly important, it's better for the patient. You don't want to offer the risk for the patient. So, and it's a quick procedure. I mean, if you're lucky, you do a couple of runs, you'll be done in 1 or 2 hours, and the patient is clot-free, and you observe for a day, you do an ultrasound the next day, and they can be discharged. So that's just really wonderful to be able to to treat them in such a quick way. They don't need to be monitored, they don't need to go to ICU.